And I want to welcome everybody to today's webinar on chemicals, drugs, and substances. Oh my. I want to introduce Christy Pollard. She's a senior consultant with Haugen Consulting Group, and she has more than 20 years of industry experience. Christy has an extensive background in coding education and consulting, and she's a national speaker on topics related to ICD-10 and CPT coding, as well as code-based reimbursement. Christy is our lead developer for our coding training materials, developing everything from webinars to web-based training to instructor-led training. When Christy is not developing or delivering training, she also enjoys helping with the audits, in addition with the DRG and APC audits. Christy devotes any extra time she has to mentoring current and future coders through her Coder Coach blog, as well as being a proud mom to Sadie, who is now toddling around the house and keeping her very busy. So Christy, at this time, I think I'm ready to turn it over to you.
All right, thank you, Kathy, and welcome everybody to today's presentation. Today, I am combining a couple of topics that you may not think really go together, looking at not just substance abuse disorders, but also poisonings, adverse effects, and underdosings, because there really is a lot of crossover, particularly in overdosings and patients who have some drug addiction, and a couple of weird things that you may not have really thought about in the past. So this slide shows our agenda for today and what we're going to be going over. And I know that one of the things that often comes up is, doctors don't use that word underdosing. So how do I know when I can use this this code? And underdosing being a newer code, something that was just introduced with the ICD-10 code set when it was implemented a couple years ago. So we are going to start out today talking about substance use disorders. And the code categories that I'm going to be talking about today fall within the F10 to F19 range. And there are coding guidelines specific to these categories of codes found in section 1.c.5.b. And I'm going to go through a couple of those. I'm also going to address some coding clinic articles that have come out. And, this presentation today was a bit of an eye-opener for me. I don't particularly enjoy digging into all the substance abuse codes. And in getting ready for today, I had a lot of discussions with my coworkers, my colleagues, about some of the different nuances with the coding here and the way that people are interpreting some of the coding guidelines. And I hope that you will find today's discussion interesting and a little more in-depth than what you may have seen in the past. So the code categories again are listed here. We've got everything. I think those of us who code the substance abuse a lot are familiar with the F10 codes for alcohol and the nicotine dependence in F17. Those of us living in Colorado and other states where marijuana is legal are probably familiar with the F12s. And I think with the current opioid crisis, all of us are probably familiar with the F11 category of codes. But I do want to dig in a little bit to the code structure. And when I started to put together this slide, my intent was to show you, how it's almost an axial structure to the codes, and it really is not. That was what I learned as I was putting this piece together. First of all, the code structure shown on this slide is just for codes F10 to F16 and F18 and 19. What is excluded from this is nicotine, and the nicotine substance use codes have a different structure than everything else. But what you'll find for all of our other drugs and substances is that at the category level, so that 3-character code level, is the substance type, as we saw on the previous slide. And the example that I've given here is F10, includes all of our alcohol-related disorders. The fourth character breaks it into abuse versus dependence versus use. And I'm going to be talking more about this as we go on, because that's a big part of how we code for substance abuse disorders in ICD-10, is whether it's classified as abuse, dependence, or use. The fifth character, it includes the complications associated with that substance use. And that can differ depending on the type of drug. It can also differ depending on whether it's abuse or use versus dependence. For example, with dependence for alcohol, you have a code for alcohol dependence with withdrawal. You do not have a code for alcohol abuse with withdrawal. Similarly, we have a specific code for alcohol withdrawal, as I had mentioned, but there is not a specific code for marijuana withdrawal. I don't know that I've ever been asked to code that, but it actually codes as an other cannabis-related disorder. There isn't a specific code for cannabis withdrawal. Some of the codes within these categories also have a sixth character that helps to differentiate or further differentiate that substance use disorder, depending, again, on the type of substance that is being used. And my guess is, depending on where you are working and your healthcare population, you're probably very familiar with certain categories here. As I said, I think we're all pretty familiar with the F10 alcohol category, and unfortunately probably with the opioid as well. But there may be a particular substance that is frequently abused in your geographic location where you see more of those than the hospital, across town. Now, I mentioned that the structure for category F17 for our nicotine or tobacco dependence does have a different structure. And first of all, there's only one fourth character option for nicotine dependence, and it is dependence. So we have a code for alcohol use and alcohol abuse, but we don't have a code for nicotine use or abuse in the F17 category. So if you're coding an F17 code, then you are reporting that this patient is addicted or dependent on nicotine and tobacco products. The fifth character for category F17 is the tobacco product itself. And there's always an unspecified option. There's also cigarettes, chewing tobacco, and other products. And an example, one of the things that we had trained when we were getting people ready for ICD-10 implementation is to watch for that terminology that physicians say the patient smokes so many packs per day or per year, because there are ways of converting any type of tobacco product into a pack per year measurement. It's really just a measurement of how much nicotine that patient is taking in. So you don't want to assume just because they say the patient has a 60 pack per year history that is cigarettes. It could be cigars, could be something else. So fifth character is the tobacco product, and the sixth character is the complication. And there are different complications here. I think most often we're coding to the uncomplicated. The one I find interesting is there is an in remission, but there's also a history of smoking or history of tobacco dependence code. That kind of makes me scratch my head and say, wow, when would I code in remission versus a history of tobacco dependence? And you see I've inset those additional Z codes for nicotine or tobacco use and abuse. The Z87.891 is the history of tobacco dependence, and the Z72.0 is the tobacco use not otherwise specified. The key for coding these is all in the indexing and the documentation. And my recommendation always is, however the physician documents it in the medical record, that's how you should be looking it up in the index. So you've got these patients who are, the physician says that the patient's a smoker. Well, it happens that if you look up smoker in the index, it leads you to nicotine dependence. So as long as you can find a way to get there by referencing the specific documentation in the record with the index, you should have something defensible if anybody ever comes back to you. Highly unlikely that they will. I do see a question that came in that I'm going to address right now, before we get too much further in here. The question is nicotine patch considered an other tobacco product? And assuming they're using the nicotine patch and they're not smoking at the moment or chewing tobacco, something that I had never really thought about until recently. I have a friend who said that her father, who's in a long-term care facility, was really cranky and agitated, and then they gave him his nicotine patch and he was okay. And I'm like, why does he need a nicotine patch? I mean, I've never seen the man smoke in my life. And she's like, oh, he's been chewing tobacco for 60 years. And I was like, wow, I just had never really thought about that. So assuming that there's no documentation in the record that the patient is also smoking or chewing tobacco or whatever, yeah, I would go with the other tobacco product on that one. Good question. So in remission, the coding guidelines were tweaked a little bit for this year. And of course, we're about halfway into our fiscal year for ICD-10. But one of the things that they addressed in the coding guidelines, they've talked about early remission and sustained remission. And I know that there's always a question about that. How do I code for early remission? Do I code that as they're currently using, or do I code it as remission? And I'm paraphrasing, but in guideline 1.C.5.B.1, I know these guidelines are super long, they do talk about the fact that whether it's early remission or sustained remission, it is coded as remission. And that all depends on the documentation in your record. And some of you may be listening to me saying, yeah, right, they don't say that. They don't tell us if the patient's in early or sustained remission. But if you just have that documentation in the record that they are in remission, you can code from that. And I always think these records are easier to code when you've had a psychologist or a psychiatrist evaluate the patient, because our ICD-10 codes mirror the DSM codes that the psychiatric industry uses to diagnose their patients. So I kind of get excited when I have to code one of these and I have a psych consult on the record, because they usually have more specific documentation, and it's very close to the terminology that we use in ICD-10 coding as well. All right, so I danced all around it, but I didn't really talk about it yet. The concept of use versus abuse versus dependence. And yeah, I know that we've been doing ICD-10 now for like 2.5 years, but I still feel like it's new, and maybe you guys don't feel like it's as new because you code every day. But when you've been coding for 20 years, 2.5 years is not that long. I still think that 10 years ago is not that long ago. So this is pulled from the coding guidelines. The guideline is noted on the bottom of this page. And basically, they say that if use and abuse are documented, you only code for abuse. Abuse trumps use. Use is, I had a glass of wine with dinner last night. It doesn't mean that I'm an alcoholic. It doesn't mean that I have wine every night, but it was Valentine's Day. I had a glass of wine. So use is just that kind of occasional use. Abuse means that you've taken that a little bit further, and you're, it's more than just a casual or occasional use. Now, if you have both abuse and dependence documented, dependence is addiction. And if you have both of those documented, then you're going to code dependence, because dependence trumps abuse. And it also trumps use. So if you have use, abuse, and dependence all documented in the record, then you assign only the code for dependence. And this can be so frustrating because provider documentation is not always real clear. I recently did an audit, and I probably wouldn't have recommended that they query, but they had abuse documented all through this record, and I can't even remember what the substance was, but I mean, I'm not a doctor, but it seemed like in the way they were treating it that this patient really was dependent. And I believe they were going into withdrawal, even though withdrawal wasn't really documented. Oh, that's what it was. It was alcohol. They coded alcohol abuse, but in order to keep the patient from going into withdrawal, they had the patient's family bring their bourbon to the hospital. So, you know, when you see something like that, and you see that they're also prescribing other things and talking about preventing the patient to go into withdrawal, that code for abuse just doesn't seem adequate. So that one I did recommend they send back for a query, because they just didn't say dependence. And I would say that your average physician who is not a psychiatrist or psychologist or substance abuse physician is probably going to be very inconsistent with the way that they document each of these conditions, which doesn't help us at all. Now that leads us to alcohol abuse with withdrawal. Now remember, I mentioned earlier there is a code for alcohol dependence in withdrawal, but there is no code for alcohol abuse in withdrawal. And this is a situation where we've got some conflicting information from the cooperating parties. Now, first of all, if you look up withdrawal state in the ICD-10 index, there is a statement that says, see also dependence drug by type with withdrawal. And then indented underneath withdrawal state is alcohol with and without perceptual disturbances, which happens to give us a withdrawal code, a dependence with withdrawal code. Contrast that to a coding clinic article that came out in 2015 that says that if alcohol abuse and withdrawal are documented, query to see if the patient has alcohol dependence. So you can see that my little elephant here has this little cloud that says query, question mark. I mean, do we query this or not? We've had quite the discussion about this amongst our staff. First of all, it's pretty standard, I think, that if the patient's in withdrawal, they are addicted, which means that they're dependent, and you would assign the withdrawal code. I feel we can back this up because the code index, the code book, coding index trumps everything else we have as far as references. So within our coding guidelines, it tells us that the conventions in the book take precedence over the guidelines. And then coding clinic is kind of a third. So if you look at the way that we order which reference is really the most reliable, you start with the book, and then it goes with the official coding guidelines, and then third would be coding clinic. So this one I thought was interesting because I didn't catch it until I put this presentation together. And so we talked about it amongst our staff, what would you do? And we all kind of feel that because the index is set up this way, that you can go ahead and code it to withdrawal. Now, if you are not comfortable with what I'm telling you right now, which is completely valid, if you have a physician who documents alcohol abuse and also withdrawal, and you don't have documentation of dependence, if you feel that you need to query within your facility, then by all means go ahead. I would recommend, because there's a discrepancy here between the coding index and the coding clinic, that you create a facility-specific coding guidelines so that it is clear for your coding staff as well as any auditors who may walk in the door. All right, that's going to bring us to our first difficult polling question. Kathy, would you launch this question for us, please?
I certainly will. So now on your screen, Christy's got our first poll. So this is where we want to know what you think. So the question is, how should alcohol withdrawal without documentation of alcohol dependence be coded? Your choices are alcohol dependence and withdrawal, or withdrawal NOS, or query the provider. So I think people are thinking. We've got responses slowly trickling in. It certainly seems like this is a difficult topic. I think we're going to have some great discussion. So yeah, if you've got a group of people in a room, what do you think? How should alcohol withdrawal without documentation of alcohol dependence be coded? So anybody else want to weigh in? Okay, we got a few more coming in. Okay, here's your last chance. I'm gonna close the poll. 3, 2, 1. Okay, Christy, we've got a few choices. We've got the majority at 76% are saying we need to code alcohol dependence and withdrawal. But we do have 24% is saying we're going to query the provider.
Okay. Well, first of all, I will say that nobody's really wrong on this one because the only true wrong answer on this one is withdrawal NOS. There is no withdrawal NOS code. For those of you who selected the first answer and said alcohol dependence and withdrawal, yeah, I think you can go ahead and go with alcohol dependence and withdrawal based off of the indexing in the code book. And it is something that could be argued if you were ever in a coding audit. For those of you who said query the provider, I'm guessing you're the ones who are like, yeah, Christy, I see what you're saying, but there's that coding clinic and I just don't feel comfortable going against coding clinic. And if that is your stance, again, I would recommend that you create a facility specific coding guideline so you at least have some consistency within your organization and your coders know what their moves should be if you're ever in this situation. So good job on a difficult question. All right, Kathy, we are going to move on and talk more about nicotine use versus dependence. And I know it feels like I'm kind of jumping all over the place. It was kind of difficult to figure out how to order this presentation. It is, there's so much weird interwoven information, but nicotine use versus dependence, I think this is the one that probably drives us all crazy as we're learning ICD-10 or we're learning ICD-10. And that is if I look up tobacco abuse, let's see, I'm going to find my laser pointer here. So if I look up tobacco and then abuse, it says see tobacco use. Okay, so I come down here and come to use, and it sends me to code Z72.0. And then it's got some subterms under there for our pregnant patients or patients who are undergoing some sort of counseling and surveillance for it. In contrast to that, if you look up smoker, it tells you to see dependence. So smokers are automatically considered to be nicotine dependent. And it's all how your physician documented it in the medical record. So there are several different ways to look up tobacco use, nicotine use, or dependence in the coding index, and you could potentially get different codes depending on how you look it up. So I would say it's kind of 50-50 from what I've seen in the audits that I've done. A lot of times the physician will say the patient's a smoker, and I'm like, boom, that's it. I can code an F17 dependence code. But a lot of times he'll just say tobacco use or tobacco abuse, and we're left with that Z72 code, which is not quite as specific. So however your doctor documents it, that's how you look it up in the index. And I know most of you are probably using encoders. If you're using a logic-based encoder such as 3M, I don't use 3M, and most of you know that I'm a book kind of purist. I love using the code book. I'm kind of a geek. So I'm always talking about the index, but if you are not aware of how your logic-based encoder is leading you, you might want to just test some of these out a little bit later, and it should be matching up to the way the book is indexed as well. So just keep that in mind. I just always talk about book coding because inevitably somebody's always asking me, how did you find that? And I have to go back to the original book. So substance abuse disorder. This is kind of a new concept over the last, I believe these were changes that were made about a year ago, first in coding clinic, and then they put the changes into the coding guidelines. So you have, people wonder why we're crazy. You have substance use, you have substance abuse, and then you have substance dependence, and you've got all three of those codes. And then if they have substance abuse and stick the word disorder behind that, it could be either abuse or dependence. So isn't that awesome? So if you have, or substance use, I should say. So if a patient has a mild substance use disorder, and that word disorder is the key, then it codes as substance abuse. But if you have a severe or moderate substance use disorder, remember, disorder is the key word in this sentence, it codes as dependence. And this is an important indexing point. So if you look only under use and then the specific substance in the index, you're going to get codes for substance use. But if you look under disorder and then the subterm substance use, then there are all of those subterms for mild, moderate, and severe, and they will send you to either abuse or dependence depending on the level of severity. This is also in the coding guidelines. So simplified the coding guidelines on this slide just by showing you that the mild goes to abuse and the moderate and severe goes to dependence. But this is all backed up in the coding guidelines as well as in the code index. So when to use substance use codes. This guideline, oh my gosh, like I said, people wonder why coders are crazy. I was talking to somebody yesterday and trying to explain I didn't even think it was that complex of a coding topic compared to what we have to deal with. And she's not a coder, and I was explaining something to her. I said, but coding's easy. Even a monkey could do it. She's like, yeah, right. This is not easy. So mad props to all of you who are out there signing codes on charts every day, because this is not an easy job. So the substance use codes, guideline 1.C.5.B.3. And this one applies to subcategories for substance use. It's written in red here. It's bolded. Remember when I said that the fourth character of your substance use code is going to tell you whether it's use, abuse, or dependence. The fourth character for these categories that are listed here that are mentioned in this coding guideline are for use. This guideline does not apply to dependence. It does not apply to abuse. It only applies to use. And the guideline says that you assign these codes only when they meet the definition of reportable diagnosis according to Section 3 coding guidelines. And that's the section of guidelines that says you report additional diagnoses if the condition required additional monitoring or diagnostic tests or extended the length of stay or blah, blah, blah. The other part of this says assign these codes only when a substance is associated with a physical, mental, or behavioral disorder and the relationship is documented by the provider. Now, they did change this guideline recently and added the word physical. So before they said, you know, you could only code this if there was an associated mental or behavioral disease, but now they're saying that you can also code it if there's a physical thing. Again, this is for use. So the idea is that if I stub my toe and go into the ER today and say I stubbed my toe, and they say, have you been drinking? And I'll say, oh, not today, but you know, I had a glass of wine for dinner last night. It was Valentine's Day. So the doctor might say, well, how much wine do you drink? Okay, so somebody might say I drink 2 glasses a week. And the doctor writes that in the chart. Alcohol consumption, 2 glasses a week. Alcohol use, 2 glasses a week, whatever. You can't code that if all I came in for was my stub toe. Now, if I came in with some sort of gastritis that he says is due to the fact that I consumed alcohol, then, and he makes that connection, then you can assign a code for alcohol use. So I think that, you know, there's been so much confusion surrounding this coding guideline, and people are saying, oh no, we can't code dependence. Can't code that the patient is opioid dependent unless the physician specifically links it to a mental or physical condition. Well, this guideline doesn't apply to dependence. It only applies to use. And the idea is that we don't want to just be coding casual substance use. And we could see this in the states where marijuana is legal. You probably see that documented in records as well. Probably not something you want to be picking up all the time unless the physician is specifically saying that it's abuse dependence or it's use with an associated condition. Hopefully that clears it all up. Let's just clear up everything today. What about nicotine though? And this one comes up a lot. A lot of people are saying, well, what do I do? I mean, the doctor documented tobacco use. Well, first of all, let's go back to this slide. Do you see F17 listed on this slide? That's not listed anywhere here. And remember that the only F17 codes we have are for dependents. There is no F17 use code. So this guideline does not apply to tobacco. So what do you do about tobacco? The problem with nicotine is that the use of nicotine and tobacco products is a risk factor for many conditions. And as a matter of fact, at the beginning of the respiratory chapter, at the beginning of your J codes, and before several categories and subcategories in the cardiovascular chapter, the I codes, there is a note to use an additional code to specify the use of either a history of tobacco dependence or tobacco use. And I think in most hospitals, if you have a cardiac patient or a respiratory patient, you're probably picking up the use of tobacco products on those cases, even if the physician isn't specifically saying that it impacts another condition, and that is backed up in the coding system. So if you are doing that, then you are okay with the tobacco products. What about e-cigarettes? Oh, geez, what will they come up next? I don't know. Does anybody have the code memorized for eating Tide Pods yet? You know, the stuff that they come up with that is out there. Right now, we've got the electronic cigarettes. And this was an article that came out in Coding Clinic second quarter of 2016. And the question specifically asked about secondhand smoke related to electronic cigarettes. It was a kid coming into a pediatrician's office who had both parents smoked electronic cigarettes in the home, and the kid had been exposed to that. So the question was, how do you code for exposure to electronic cigarettes? And the response was that we assign this code Z77.29 for contact with exposure or contact with an exposure to other hazardous substances. And while some of e-cigarettes do have nicotine in them, not all of them do. Some of them have some other products, but they do have chemicals in them that they think can contain some particulates that can be hazardous to your health. So I would argue that if your patient is a smoker of e-cigarettes, I would still use this code. And Coding Clinic doesn't say that. Christy says that. That's not really an official resource, but they're exposed to those particles. But I would have a hard time coding nicotine dependence or smoking if the patient is smoking these e-cigarettes, since we don't know what is in those. All right. Well, that's going to wrap it up for substance use and abuse and dependence, although I'm sure it's not a dead topic because I'm sure there are questions out there. We're going to move on to, real quickly, long-term use of medications, because there are a couple of things I want to point out here. Long-term drug therapy. And if you look at the codes within this category, the titles all have the word current in parentheses. And remember from our coding guidelines and conventions that any words in parentheses are non-essential modifiers, which means that the patient's condition doesn't have to meet that terminology. So long-term drug therapy, it could be something they're taking currently or something that they took years ago. For example, steroids have a tendency to cause a lot of long-term problems. And even if you stop taking it, those problems don't necessarily go away. So that might still be something you want to report. The other thing is that we want to be careful, and some of the coding guidelines allude to this specifically for diabetes and insulin, that, you know, if the patient was just put on that medication during this hospital admission, that's not long-term drug therapy. We're talking about things that could potentially cause health hazards because the patient has been on them for an extended period of time. Aspirin, Coumadin, you know, any of your blood thinners are a big deal. The steroids, as I mentioned, because it can break down some of your body tissues. The other thing that I'll point out here is there is an excludes to note that says that you can use this code, the codes for long-term drug therapy, in addition to your drug abuse and dependence codes. And that's going to become apparent on our next slide as we talk about methadone maintenance therapy. And this is an old Coding Clinic article. I dug this one up out of ICD-9. And the concept, I think, is similar and translates over to ICD-10. So methadone maintenance therapy, or MMT, is a therapy, a treatment for heroin and narcotic addiction. And with our current opioid crisis, it is something that you may see. A patient may be coming into the hospital on methadone specifically for the treatment of a narcotic addiction. So this, the Coding Clinic article says that if a patient is on methadone maintenance therapy for substance dependence, then you code it as dependence and not a long-term drug use. So that was kind of the question, is should this be a Z code for long-term drug use, or should it be dependence? And they're saying code it as dependence. But be really, really careful, because methadone can also be prescribed for chronic pain. There's some people who can't tolerate opioids, and so they give them methadone. If you don't have any documentation in that medical record that the patient is or ever was addicted to any kind of a substance, I would query. Last thing we want to do is label a patient as being dependent when they're not. So, you know, you might have your great Aunt Mary who's got this chronic pain, and for some reason she can't take morphine, so they give her methadone. Well, we don't want to be giving her a dependence code. And in that situation, you can certainly set a facility coding guideline. If you have a patient who's on methadone maintenance therapy for chronic pain without dependence, you might consider adding a long-term use code. That's kind of up to you. Moving into adverse effects for poisonings, or adverse effects, poisonings, underdosings, and toxic effects. And all of the coding guidelines do a really good job of defining adverse effects, poisonings, and underdosings, but they don't really say what a toxic effect is. At least I didn't feel like the guidelines added a whole lot. But we do need to know the difference between adverse effects and poisonings. This isn't really anything new. Adverse effect is a reaction to a drug that's been properly prescribed and administered. So not just properly prescribed, but also properly given to the patient. A poisoning is a reaction to the improper use of a substance. And we're going to talk more about poisonings here coming up. And then underdosing is taking less of a medication than prescribed according to the manufacturer's instruction. And there have been a lot of questions about coding of underdosings because that is new over the last couple of years with ICD-10. So a couple of basic coding guidelines. First of all, these are combination codes that include both the substance and the intent for poisonings. On poisonings, we do not assign a separate external cause code. Yay! Also, we don't code directly from the table. We refer to the tabular list. And I call that a rookie mistake when I can tell when you've only coded from the table or haven't been using an encoder because you forgot your 7th character. These do have 7th characters and those aren't listed in the tables. You also want to use as many codes as necessary to describe the substances. If they listed out 3 different substances that were responsible for a poisoning in a patient, you code them all out separately, unless you have the same code that would describe the causative agent for more than one medication. For example, I've seen that with benzodiazepines. If a patient has a poisoning due to a benzodiazepine, there are 2 different substances, 2 different named substances that both happen to code to the single poisoning benzodiazepine code. You only report every ICD-10 code you have once. These codes, again, as I mentioned, do have 7th characters for initial encounter, D for subsequent encounter, and S for sequela. For adverse effects, this is a medication that has been correctly prescribed and properly administered. And a couple of examples would be nosebleed due to Coumadin therapy, as long as the patient was taking that as prescribed. Toxic encephalopathy due to medication therapy. And the way that adverse effects are sequenced is the nature of the adverse effect or the manifestation is listed first, followed by your adverse effect T code. So your 5th or 6th character on an adverse effect should be 5. The first adverse effect example I have, this is a patient who presents with bacterial pneumonia, and she is in an immunosuppressed state due to steroid treatment for rheumatoid arthritis. I didn't pull this specific example from Coding Clinic 3rd quarter. They didn't actually have specific codes listed here. But the interesting thing they said is that you don't code the immunocompromised state if it is an adverse effect of a medication. So in this case, we code the J15 for the pneumonia first, and then we assign our adverse effect of those glucocorticoids as a secondary. Looks kind of odd, you know, how does a glucocorticoid cause pneumonia? But because it did compromise the patient's immune status, it is coded as an adverse effect. The second example, patient presented with an ischemic stroke and TPA was administered, and the patient had a hemorrhagic conversion or transformation due to the TPA. This is another example that I pulled from Coding Clinic from 2nd quarter of last year. And in this case, you're going to code your manifestation, which is the cerebral infarction. And then we have that it was a conversion. So there are a couple of different strokes to code there. And then you add your adverse effect as a secondary code. So adverse effects T code is never going to go first. The third example, and this is such a common example, a patient who has a post-op intra-abdominal hemorrhage due to coagulopathy due to prasugrel and aspirin. I should just use the trade name. It's Effiant and aspirin. And this code D68.32 was a new code with ICD-10, which is hemorrhagic disorder due to extrinsic circulating anticoagulants. Prior to ICD-10, we had one for intrinsic. This one is for extrinsic, which is the code that we use when the patient is bleeding because of medication. And we've got our 2 T codes there to show that the patient had adverse effects from 2 different drugs that thinned out his blood. And then also, because this was specified as a post-operative hemorrhage, we've got a complication code to go along with that. So moving on to poisonings. Poisoning, again, is improper use of a substance, and that can either be an overdose, it can be the wrong substance given in error, it can be the substance taken in error, or the wrong route of administration. It can also be any substance that was taken with alcohol, because that will quite commonly create some sort of an interaction. Now, the sequencing with poisonings is that the T code goes first, and your 5th or 6th character for the intent is either going to be accidental, self-harm, assault, or undetermined. Coding guidelines tell us that if the intent is unspecified or unknown to the physician, to us, through the documentation, you code it as accidental. And this is something I think we're all fairly comfortable with as coders. It is something that can be a problem when people are interpreting our data on the back end. They may say, you know what, this wasn't accidental, because maybe they determined at a later time it wasn't. But you have to code with what you have documentation for in the record. And it's also a great testimonial to why we need to have coders who understand the codes and the coding guidelines assisting in data interpretation. The undetermined intent means that the provider doesn't know. So if the doctor says, you know what, the patient took this medication and I don't know if it was suicidal or accidental, well, then we would code that as undetermined. So don't confuse unspecified with undetermined. Undetermined means the doctor doesn't know. Unspecified means the doctor just didn't tell you. It's not documented in the record, and that would code as accidental. This tells us also to code substance abuse and dependence if applicable, and that could be something that would be quite common. If the patient is admitted to the hospital with an overdose of heroin, and they're also addicted to heroin, then you would have your dependence code as well as your poisoning code. Again, more examples of poisonings. Error in prescription, that happens. I've heard of people who go to the pharmacy and when they get their pills, they read the little information sheet that came with their pills. There should be a physical description of what the pills look like, complete with any numbers that are printed on them. And if it doesn't match, I would recommend taking it back. Sometimes errors in prescription administration can be found that way. Intentional overdose is pretty obvious. Non-prescribed drug resulting in drug toxicity. So if you're taking your mom's narcotic medication from her last surgery, and something happens, then technically that would be a poisoning because it wasn't prescribed to you, and technically you shouldn't be taking it. Drug-alcohol interaction we already talked about. Inhalation of chemicals, gases, fumes, or vapors. This one's awesome when you look at the index. If you look at the first box, inhalation of gases, fumes, or vapors, NEC, it says code to T59.9. And if the agent is specified, see the table of drugs and chemicals. Then you look down here under smoke inhalation. Due to chemicals, gases, fumes, and vapors, J68.9. So which one is right? Should I be coding my T code or should I be coding my J code? If you look to the tabular listing under that J68 code, there is a note underneath that code that tells you to code first the T51 to T65 to identify the cause, and that would be your your poisoning. So this is another example of why we should never code from the index, because you miss important sequencing information like this. All right, Kathy, that brings us to our next polling question, please.
Okay, here's the question. You have an overdose of Tylenol. The MD is unsure whether it was accidental or self-harm. Do you code it as undetermined, accidental, or as self-harm? What do you think? We have an overdose of Tylenol. The MD is unsure whether it was accidental or self-harm. Do you code as undetermined, accidental, or self-harm? Responses are slowly coming in. We've got the majority. Anybody else want to weigh in? I'm going to close the poll. 3, 2, 1. Okay, Christy, we've got the majority at 82% saying, nope, we want to code it as undetermined, but we do have 18% of our audience is saying code it as accidental.
Okay, so remember that if the physician is not sure, and he documents that he is not sure whether it's accidental or self-harm, it codes as undetermined. So the correct answer on this one is the first one. It would only be accidental if he didn't document the intent. All right, thank you, Kathy. So we have a poisoning example, patient admitted to acute care with acute on chronic respiratory failure following an accidental heroin overdose. And this patient has a poisoning code that is sequenced first. Remember, poisoning codes go first. 7th character is A because this is his initial encounter for treatment of this particular condition. And then the acute on chronic respiratory failure is a secondary diagnosis. Now, this next example was taken from a coding clinic, and this one kind of blew my mind. Once again, our jobs are really hard because we've got this coding guideline that says that poisoning codes always go first, but then we have this patient who is the same patient in our previous example. He's done with his acute care, and now he's being transferred to long-term care for continued treatment of his chronic respiratory failure following a heroin overdose. And coding clinic says you put your J code first for the chronic respiratory failure, and then a poisoning code with the sequela 7th character. And the reason for this is they say that the sequela coding guideline takes precedence over the poisoning sequencing guideline, that this patient isn't really being admitted to long-term care for anything to do with his poisoning. It really is just, working on his chronic respiratory failure, and this is now a sequela of the heroin overdose. So if you've ever thought that you don't really need coding clinic, I think here's a really good argument for one of those weird situations where you would need it. Toxic encephalopathy is another interesting one, and there are some indexing or some tabular issues that they did not fix last October that I really wish they had. So first of all, there are no issues with toxic encephalopathy due to poisoning. When you have a patient who is admitted with toxic encephalopathy, this particular patient took too much lithium in order to attempt suicide. And so in that case, we've got our T code, which goes first, and G92 for the toxic encephalopathy is second. Now, if you look at the code entry for G92 from the tabular list, there's a code first note that says code first if applicable, drug induced, and it gives that code range. And this one makes sense to me because our poisoning codes go first, unless of course you've got that weird sequela patient we just talked about. The problem is if it's toxic encephalopathy due to an adverse effect, we have a coding guideline that says that adverse effect T codes do not go first. So Coding Clinic first quarter 2017 did tell us that the proper way to sequence that is to put the toxic encephalopathy first, followed by your T code. So I know earlier I told you, trust your book, and now I'm telling you don't trust your book, but this particular tabular entry only takes into account toxic encephalopathy due to poisoning. It does not take it into account if it's an adverse effect. So something to be careful of there. Underdosings. So this is taking less of a medication than prescribed by a provider or manufacturer's instruction. The sequencing for underdosings is that your exacerbation of the medical condition for which that medication was to be taken goes first. And then your underdosing T code is second, and it'll have a fifth or sixth character of 6. You also can add non-compliance codes or complication of care codes if known. Now, underdosing. Doctors don't use that term. What a doctor will say is the patient is non-compliant with medication regimen, or the patient's not taking their medication. Either they're taking too little or they're not taking any. Non-compliant is a pretty common term that physicians use in their documentation. So if you look under non-compliance with and then medication regimen, you'll see that it then gives you all these other options for underdosing and why. Was it intentional? Did they not have the money? Was it unintentional because of the patient's age-related debility? Then I would say out of all of those reasons, financial hardship is probably the one that I see documented most frequently. A lot of times if they think it's due to the patient's mental debility, they don't really know for sure if that's it, so it's kind of hard to tell. So this is going to lead us to our third polling question. And actually, I think I'm going to skip this one because we are getting really, really close to time, and I threw a lot of polling questions in here today. The correct answer to this one, so it's which of the following documentation can be used to code underdosing? Is it A, non-compliance, B, not taking meds, C, taking a reduced dose, or D, all of the above? And on this one, I would say that probably all of the above, as long as you have that documentation that the patient was not taking as much of their medication or wasn't taking their medication when they were supposed to be. There is a guideline for insulin pump malfunction. These are guidelines that I always have to review when I come across them because it's just not something that sticks in my brain so much. But how you code an insulin pump malfunction, besides coding the mechanical complication code, it really depends on whether the fact that it broke gave them too much medication or didn't give them enough medication. So it can either be an underdose or an overdose situation. And you're going to have 2 T codes, one for your mechanical complication and one for your underdose or overdose. And then that brings us to chemical burns, which seems really weird. But I remember when I was learning how to code, it's like, the patient spills bleach on their arm. That's not really a poisoning, but I can look up bleach in the table of drugs and chemicals. So what do I do? Well, ICD-10 is very clear that corrosions are chemical burns. And in the burns, what we classify as a burn is a thermal burn. And then any burn due to chemicals is a corrosion. And these are classified to codes T20 to T25, very similar to burns by depth, extent, and the causative agent. And the coding guidelines that apply to burns are the same guidelines that apply to corrosions. So if you come across something where the patient has a chemical burn and you're not real familiar with these coding guidelines, just put this in the file in the back of your head to remember this. So again, corrosion versus poisoning. If the substance is taken internally, and I guess there are some people who eat or drink bleach, those kids who eat the Tide Pods right now, which is such a big trend, that's a poisoning. But if it's a substance that comes in direct contact with the body's tissues, then it codes as a corrosion. And just a couple of additional slides that pull in some information about the guidelines for corrosions. I really felt today it was more important to talk about the substance abuse and the poisoning and adverse effect guidelines, but wanted to make sure that you kind of had some reminders on these too. So There are sequencing guidelines for corrosions. Again, they are very similar to what we have for burns. And they do have 7th characters. And there are also codes for burn or corrosion by body region. And the last polling question is asking how should a chemical burn due to bleach be coded? So is it a burn, a corrosion, or a poisoning? And the answer to that one, again, is going to be the corrosion. I think I've said that word about 60 times now in the last 6 slides. All right, so that is going to wrap up today's presentation. There's a list of the references that I used in preparation for today. That one coding clinic for ICD-9 was about the long-term use or the methadone maintenance therapy, coding as dependence. And that is going to do it. I don't think we have time for questions, but I'm sure Kathy will make me answer them in writing later. Kathy?
You are absolutely right, Christy. We are at the top of the hour and want to be respectful of everyone's time. So we did have a couple questions come in. So what we will do is we will put an FAQ sheet together. We will attach it to your follow-up email. So look for the follow-up email within 2 days, and that will contain the recording link, the FAQ document, as well as your CEU and handouts. So we hope you enjoyed today's presentation. I want to thank Christy for another fabulous webinar. And we also included upcoming events and webinars. So you can see next month we've got for the Prophy Coders, Coding from the Op report on March 14th. And Facility Coders, we are going to talk about Wound Care Part 2. So thank you very much for your time. We enjoyed it, and we hope to see you again next month. Thanks. Bye-bye.